It is time for another Puscast, reviewing the first 2 weeks of February 2010. For those who are sick of the intro, you can skip ahead to the next chapter. But there's business I need to take care of, like this is CME, so you can take the online quiz and get a half an hour of free CME. And since it's CME accredited, I need to mention my conflicts of interest. None. There, that was simple, now wasn't it? And then, of course, I need to harp on the fact that you need to participate in my worldwide multimedia empire with my Gobbet Opus podcast, with my Quackcast podcast, with Rubor, Dolor, Kalor, Tumor, my infectious disease blog, and then my twice-monthly screed over at Science-Based Medicine. Because the world needs more Mark Crislip. But then, hey, you know that. So anyway, with that little business out of the way, we will get on to the literature. And in the minute and 30 seconds it takes to listen to this intro, you could have logged on iTunes and written me a fabulous review. People and peoples have died all throughout history. And they've been taxed as well, I suppose. And in the old days, they didn't really know why people died. Now, there was this large outbreak in 1616 in the Native Americans that there have been large speculation about over time. These are tribes that died in northeast United States just prior to the onset of the Pilgrims. In fact, there was a high mortality rate in the population of the time, which some local writers of the era estimated to be around 90%, that allowed the Pilgrims to land and not get kicked off of the New England coastline. My middle name is Alden, and my direct ancestors came over on the Mayflower, so I wouldn't be here today if it hadn't been for this particular plague, perhaps. Now, people have postulated what may or may not have caused this outbreak, and this article in Emerging Infectious Diseases suggests that it was severe leptospirosis. Others have thought it was yellow fever or plague or smallpox, but the clinical syndrome that they had at the time of patients were bloody nose, jaundiced, fevers that killed off the population. This reviewed the ecology and previous explanation of this plague in Northeast in 1616. And they compare and contrast all the different illnesses that it could have been and come to the conclusion that it's probably severe leptospirosis. Now, while we don't think of leptospirosis as being that fatal, in prior outbreaks, such as Japan, they've had 48% mortality rates and 32% rates of death in Europe. So it's not unheard of. So it's an interesting hypothesis that it was leptospirosis that killed off the Native Americans in 1616. They finished by noting that Squanto, who helped the Pilgrims, was one of the few survivors of that epidemic, but then he subsequently helped out the Pilgrims and then died several years later, having a fever and a nosebleed of the Indian disease, which indeed may have been leptospirosis. The ID literature has no end of speculation on a variety of outbreaks through history and individual deaths through history as being due to infectious diseases. It's what makes ID endlessly fascinating. Unless your name is Bruce Wayne, you're probably not going to care, but there's been a white nose syndrome fungus in bats in the northeast United States. This fungus has killed off about 1 million bats or more, and caused some bat populations to decline by virtually 100%. This white mold grows in the faces of the bats. They subsequently do not eat and die of starvation while they're hibernating. The organism is Geomyces destructans, which is a horrible name. Now, this has been confined to the United States and the Northeast area, and they've now found sample in a bat in France. So perhaps it's always been there. Alternatively, perhaps it's now spread to Europe, where it's going to kill off the bat populations of France and the rest of that part of the world. Why should you care? Well, bats eat humongous amounts of insects, especially mosquitoes. And one would wonder if the death of the bat population since 2006 is going to lead to a resurgence in mosquito-borne illnesses in places where the bats are dead. Remember that the other mold that's going through the world right now and has killed off maybe 50% of the amphibians and frogs in the world. So there will also be a shortage of frog legs. And if you want to have a good giggle, I'm going to pronounce the name of the fungus that has been going after amphibians, causing chytridiomycosis. It's the Batrachochytrium dendrobatides. And I said that so wrong, but I'm a doctor, not a microbiologist. Actually, I'm kind of both when you think about it. And so keeping up on the ever-expanding number of organisms that can harm human beings, there is the par-echovirus. The par-echovirus is in the family Picornaviridae, and it causes a variety of diseases in humans similar to the enteroviruses, such as aseptic meningitis, gastroenteritis, encephalitis, and respiratory disease. Most kids probably have an asymptomatic infection before age 2. This study looked for the presence of viruses in children less than 2 who died. They did 1,263 autopsies, and they found evidence of par-echovirus in 18 kids and thought it contributed to the deaths in 16 of them. So this may be a cause of death in young children. Now, association is not causation, but it is important to know that all these viruses are out there. Can you get CMV more than once? Maybe yes, maybe no. This study looked at CMV seropositivity in healthy women. They compared their sera against one strain of CMV, and they followed them over 3 years looking for reaction to other strains of CMV. They found that at a rate of about 10% per year, women were exposed to a second strain of CMV and had an infection from it. Although they did not have, as they point out, the classic risk factors for CMV, including sexually transmitted infections, sexual practices, and caring for young children. They also noted that women who had a more broadly active antibody response were less likely to be reinfected with CMV, so there is some cross-reaction from strain to strain. But this study would suggest that you can get CMV more than once in your lifetime. This has significance both for pregnant women who can pass it on to their children, and I assume for transplant patients as well. Although this study did not address the issue of congenital CMV under these circumstances. And they also don't mention if patients had a clinical syndrome or other symptoms associated with the reinfection with a different strain of CMV, which of course would be of some utility for them what practiced medicine. Now that H1N1 has dribbled off the court, at least for the time being, and seasonal flu appears to have not bothered to start yet, what have we had from H1N1? CDC estimates for your entertainment. 84 million cases of H1N1 are estimated to have occurred. They estimate a median of 250,000 patients were hospitalized, and perhaps anywhere between 8,000 and 17,000, with a median of 11,600, may have died from influenza. The vast majority of cases have been those who have been young. 60% have occurred in the age 18 to 64, and another third have occurred 17 or younger. Although old people, if they got it, were more likely to die. 77% of the deaths occurred in those between ages 18 and 64. So the estimates are this pandemic had a pretty significant morbidity and mortality. And I'm sure some people listening to this can say, that's nonsense. I don't see that kind of death rate from flu. Well, remember, 40,000 people die every year from car accidents, and another 30 or 40,000 die every year from handguns. How many people do you know that have been shot or killed in a car accident? Or, for that matter, shot while having a car accident? Herpes and acyclovir go together like peanut butter and jelly. Well, maybe they don't taste as good. The ulcerative disease of herpes helps facilitate the transfer of HIV, and when patients get active HSV, they tend to increase the replication of their HIV. Furthermore, if you give patients who have HIV acyclovir, you decrease their virus of HIV in their blood. So there is some potential benefit to treating patients with HIV and HSV for both viruses simultaneously. But you may ask, will that help decrease the transmission of HIV? And the bummer of it is negatory, according to the New England Journal of Medicine. And I will simply quote the conclusions here. Quote, daily acyclovir therapy did not reduce the risk of transmission of HIV-1, despite a reduction in the plasma HIV RNA by 0.25 logs copies per millimeter and a 73% reduction in the occurrence of genital ulcers due to HSV-2. Bummer. So while you can decrease the HIV and the genital ulcers, it's not going to help protect the spread of HIV in patients. And I've been inclined for a while to have all my HIV patients who also have HSV be on chronic suppressive acyclovir and not just treat their symptomatic disease. Like hepatitis C, like CMV, HIV has subtypes as well, cleverly called A, B, C, and D. This study looked at progression of HIV depending on subtype of HIV, and they found that while subtype D was the least common cause of HIV infection, accounting for 51 of the 679 types, those who had type D had a fourfold faster rate of CD4 decline after adjustment for gender, ethnicity, and baseline CD4 count, and were more likely to have viral rebound. So type D is a bad strain of HIV. You may remember a journal article a while back that suggested that the HIV virus was becoming more virulent with time. The suggestion that as patients don't get HIV spread as commonly as before because of safe sex and heart, that perhaps the organism is mutating to become more aggressive in its ability to spread, which would make sense, since if it's easily spread, there's not a lot of reason for the organism to be more virulent. Maybe the type D is that strain that will be selected for with the current regimens and behavioral activity that we recommend for the prevention of HIV. Infectious diseases is nothing if not applied evolution. One would think that I knew everything by now, but I don't. That's why I do this podcast. Damn you, medicine. Now, I always thought that lymphochorial meningitis was due to people that handled hamsters and guinea pigs, and that it was pet owners that got LCM. Not true. Evidently, there was a study in Washington, D.C. that found that 8 to 11% of patients having a febrile neurologic illness between 1941 and 1958 were seropositive for LCM. And it can be found between 4 and 14% of mice in the United States. So LCM is not uncommon in wild mouse. This was someone who lived in New York, New York, who had no risk factors for infection and came down with aseptic meningitis during the winter with low sugar and a lymphocytosis. And they checked for LCM and it was positive. So they went looking and the patient denied any risk factors. And, quote, New York City Health Department officials attempted an investigation of the patient's home and surroundings to look for evidence of rodents or rodent excreta, but were unable to do so due to the patient's non-compliance. So the last I was not crossed and the last T was not dotted. But LCM may be more frequent as a cause of aseptic meningitis than I had hitherto suspected, so I will start looking for more LCM in the future. Now, you may not be aware of this, but Dr. Wakefield had his article retracted in its entirety from the Lancet. He purported to show a link between the MMR, specifically measles, and autism. His study has never been replicated and was found to be both bad medicine and, even more importantly, unethical medicine. However, as a result, MMR uptake in the United Kingdom declined dramatically, and they've been having an outbreak of MMR-related illnesses in England. Now, this kid went to England for vacation, and he brought home with him mumps. He brought it to New York, and now they're having a big outbreak of mumps in New York and New Jersey. They're now up to over 1,500 cases of mumps, including patients, of course, who've had vaccination. The anti-vaccine wackaloons say, look, the vaccine doesn't work. People getting vaccinated, they're getting the mumps. Please remember that all the vaccines are not 100%. And once you get a certain amount of protection in a herd, the disease doesn't spread as long as it's not reintroduced by some vector who gets the disease from an endemic third world country like England. Be that as it may, mumps is now in an outbreak in New York and New Jersey, and it's only an airplane flight away from your hospital. The host immune system is always more important than any piddly-ass antibiotic I can offer. And this again is shown with Babesia in a study that had 3 patients, all of whom had a lymphoma of one sort or another, who were treated for their Babesia with azithromycin and atovaquone. The organism became resistant in all 3, one of whom died of their Babesia. Resistance is inevitable, saith the Borg. Yet another example of how we breed resistance in treating patients, sometimes even with appropriate doses of antibiotics, if the host immune system is not there to clean up the mess. It's the epidemiology that always gives me hoots and giggles in infectious diseases. For example, tularemia. Oh, God, I'm an awful singer. So there's this outbreak of tularemia in Hesse, Germany. They had an outbreak of 39 people who participated in a hare, i.e. bunny rabbit hunt. Now what they did when they got done with the bunny rabbits is they hung them from a tree after disemboweling them. Ooh, that must have been fun. And then rinsed them with a water hose. As a result, those that were within 5 meters of the rinsed, disemboweled bunny rabbits came down with inhaled tularemia. And they looked at the hair parts, again, H-A-R-E, and found 11 of the 14 hair parts had tularemia in them. So they estimate that at least half the cases of tularemia were inhalational as they hosed down the hair, H-A-R-E, which I just think is crazy, the way people can pick up infectious diseases. I guess it gives you a whole new perspective on the hair club for men. Medicine is always more complicated than you expect. I think it was last time we talked about the New England Journal article where patients had their nose cultured for staph, and those who were positive for staph received nasal mupirocin and hibiclin shower for 5 days, and they resulted in a decrement in their surgical infection rates by about half. Well, where's that staph coming from? Well, this study looked at staph carriage as a risk for surgical site infections in orthopedic surgery. They had 3,900 patients who underwent orthopedic surgery. Of those, 77 developed the surgical site infection, including 22 that were related to Staph aureus. Staph aureus was isolated from the nose of 20% of the patients at the time of surgery. They turned out that if you did carry staph in your nose, it was a risk factor. Okay, we already know that. However, and I'll quote the article, only 9 subjects exhibiting Staph aureus surgical site infection had been found to be carriers before surgery. When compared, 3 pairs of strains were considered to be different and 6 similar. In most cases of Staph aureus surgical skin infection, either an endogenous origin could not be demonstrated, or preoperative nasal colonization retrieved a strain that was different from the one recovered from the surgery site. What a pain. So just because you're not carrying staph in your nose doesn't mean you're not going to get a staph infection. And if you do carry staph in your nose, that may not be the strain that's going to infect you. The more I know, the less I understand. And it's also been noted that nasal colonization can miss 10, 20, even 30% of staph carriers. It all depends on where you stick the swab. The throat, the rectum, the vagina, the skin folds are all places that can carry Staph aureus without being in the nose. So do you treat everybody preoperatively? Do you take one swab and put it in some interesting order to try and determine if the patient is colonized with staph? I would recommend the rectal position last. Or do you treat patients who are only colonized with the knowledge that you're going to miss some? And if you do treat everybody, you know that's going to drive mupirocin resistance, which is like 14% in Canada, and there's increasing resistance to hibiclins as well. So no matter what you're going to do on your surgical ward, it's going to come back and bite you in the ass. I have become increasingly disillusioned with meta-analyses of late, since meta-analyses of meta-analyses show that they're flawed, and the subsequent randomized controlled trials will often show meta-analyses to be wrong. I find this a lot in the wackaloon literature, i.e. things like acupuncture and homeopathy, where the meta-analyses are only as good as the studies that go into the meta-analysis. This study was published in The Lancet, and they looked at the meta-analysis of adjunctive dexamethasone for bacterial meningitis. So what did they find? Well, they found in their population of 2,000 patients from 5 trials that adjunctive dexamethasone didn't either decrease death or neurologic disability, and that there was no significant treatment in any of the pre-specified subgroups, which were death at the time of first follow-up, death or severe neurologic sequela at 1 month, death or any neurologic sequela at first follow-up, and death or bilateral hearing loss at first follow-up. How do you follow up if you're dead? I'm not sure. But in reviewing all of these patients, they found no efficacy of dexamethasone in the treatment of bacterial meningitis in this meta-analysis. So, as far as they're concerned, it's unproven crap. I got a patient right now with bacterial meningitis, and I have them on dexamethasone. Crap. I suppose it's a good thing I don't believe in meta-analyses, because as Will Rogers said, I never met an analysis I liked. And I know you're saying to yourself, I've heard that joke before. He said that before. Hey, you try and do 5 years of twice monthly podcasts and come up with new lines every time. This isn't easy, you know. One of our labs here in town offers the PCR as a way to make the diagnosis of pneumocystis in patients, and is an adjunct to stains, or so I would have thought, until 2 studies that were out this month in clinical infectious disease. One looked at pneumocystis colonization in people who died either of violent causes, accidents, homicides, or suicides, or non-violent diseases such as a big heart attack. And they did an autopsy, and they looked for pneumocystis in their lungs. And they found evidence by PCR of pneumocystis in 65% of patients who died of no particular infectious disease cause, i.e. heart attacks and moida. Another study did a similar thing in older adults who were getting bronched, and they looked and found pneumocystis in 21% of patients who were getting bronchoscopy for other reasons, and they paired this with a nasal swab to increase the yield of pneumocystis. So definitely pneumocystis is part of the normal flora, and a PCR of the lung looking for pneumocystis should be taken with a grain of salt substitute as a potential etiology of this disease, in the wrong patient population, of course. This month, the Infectious Disease Society of America released their guidelines for the treatment of cryptococcal disease. And as I've mentioned before, the Infectious Disease Society of America guidelines are a good substitute for Ambien. However, not every country has the resources to use things like lipid complexed amphotericin at $400 a dose. One of those countries soon to be the United States at the rate we're going. This study came out of Africa and looked at the treatment of Cryptococcus using high-dose fluconazole with or without flucytosine. They found that the combination was efficacious. They compared, and this is high dose, 1,200 milligrams a day of fluconazole versus 800 milligrams a day plus 5-flucytosine. And they had benefit in the combination group, both at 2 weeks with markedly decreased deaths in the combination group, 10% versus 37%, and at 10 weeks, 43% versus 58%. Now, given the number of people in this country who do not have health care insurance and cannot afford IV antibiotics, high doses of fluconazole plus flucytosine would be an encouraging combination in our patients as we slowly slide into economic disrepair. I'd say this is George Bush's fault, but whiny little crybabies complained about my bitching about Bush destroying the country. It's been a year since he ruined our peace and prosperity. Quit whining about it, so I won't. Babies. And now for the hodgepodge section of our podcast, the unreferenced, where I'll quickly go through the stuff I didn't feel like talking about at length. You ready? First, there was a reference in CID that showed that some strains of H1N1, or perhaps some strains of human beings, can only be isolated in the lower respiratory tract, but not in nasopharyngeal swabs. Suggests that certain hosts or particular variants of H1N1 prefer the lower respiratory tract as a site of infection. The important thing being here is that a negative swab doesn't rule out influenza with H1N1. A study looked at the efficacy of the trivalent vaccination, the standard flu vaccine, for seroconversion of nurses during the H1N1 pandemic. They found that those who received the trivalent influenza vaccine had a seroconversion rate of 7% versus 11% for those who did not receive the vaccine, suggesting there's some slight cross-reactivity between seasonal flu vaccine and H1N1. Now, besides mumps spreading in the world, we're seeing more measles in England, thanks to the lack of an MMR. They have a case of measles that looked to the clinicians like HIV seroconversion. And you think about it, you get a rash, sore throat, cytopenia. That's classic HIV disease. It's also measles. Because this was in an adult, they did not think of measles as the cause of disease. The study looked at needle length in vaccinations in children and found that fat children didn't get as good a response. Obese children did not get as good a response to the hepatitis B vaccine if they used a 1-inch needle as opposed to a 1.5-inch needle. The longer needle probably got it down into the muscle where it worked better than putting it into the adipose tissue. So obese children should get vaccinated with long needles. Q fever is found in dairy cattle. They find that 11% of individuals who mess around with cows are seropositive for Q fever, and veterinarians have a rate of about 40% for Q fever. So if you're involved with Danish dairy cattle, and probably dairy cattle anywhere, think of Q fever. I talked earlier about the difficulty in finding staph colonization in patients. This study looked at 250 pregnant women and found that Staph aureus, specifically MRSA, was only found in rectovaginal specimens in 10.4% of pregnant women. So, MRSA can be in any number of places. A report in CID suggested another emerging infection, E. coli pyomyositis in neutropenics. Certainly, pyomyositis is usually due to Staph aureus or Staph epi, This study, they had a series of patients who had it from E. coli, specifically the ST131 strain, which is both quinolone resistant and is an ESBL producer. So this particular organism may be a tad more virulent as well as resistant. Archives of Internal Medicine looked at the dangers of passive smoking and found that people who are exposed to passive secondhand tobacco smoke had an increased risk of developing tuberculosis. They say that passive smoking accounted for 13.7% of active TB and 18.5% of culture-positive TB. So I'm glad they banned smoking in my restaurants because I've always been afraid of getting tuberculosis in the restaurant. Single dose of amphotericin B in the liposomal format at 10 milligrams per kilogram cured 304 of 304 patients with visceral leishmaniasis, or Kala-Azar, which I think was the person Kirk battled in one of the movies. And finally, this study looked at the relationship between the population density of attorneys and the prevalence of MRSA. They found that a high density of attorneys, but not a high density of physicians, was associated with increased MRSA rates. They hypothesized that fear of lawsuits and attorney population density would be a surrogate marker of this, led to more antibiotic use, and drove MRSA resistance. I love it. And that's the last of our hodgepodge. Okay, you can go away now. It's just the ending blather I have to do. Okay, this is the end of the first 2 weeks of the February podcast 2010. The references are available on the website. It's CME accredited. Now that you've listened, take the online quiz and get a half an hour of free CME. Brought to you by Puscast LLC, publisher of the Persiflators Annotated Compendium of Infectious Facts, Dogma, and Opinion. Your uber hyperlinked electronic guide to infectious diseases at Puscast.com. Don't forget to join my multimedia medical empire. There's the Quackcast, voted best health podcast by some deeply disturbed people. There is the Goblet O Pus, my infectious disease adventures of a pus whisperer, available on iTunes. Ubor, Dolor, Kalor, Tumor, my fabulous blog on infectious disease over at Medscape, and finally my twice-monthly ditherings over at Science-Based Medicine. Remember, the world needs more Mark Crislip. This is copyright 2010 under the Creative Commons license. The music is by my son when he was 12, improvising on the guitar. Go ahead and send me an email. Not a chance in hell I'm ever going to answer it. I have like 2,000 or 3,000 unanswered emails that just look at me off my Gmail account, calling me a lazy, inconsiderate bastard, which is true. And as always, thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. I will continue to follow along with you. Thank you. In dictation, goodbye.